Hi, this is Marisa, and today I'm presenting to you PJ, who is a 61-year-old African-American woman presenting to the clinic for her annual checkup and a recent history of UTI and yeast infection. For history of present illness, she had a UTI in April treated with Bactrim, vulvovaginal candidiasis in August treated with fluconazole, and a second UTI in January treated with levofloxacin. Currently, she has no symptoms of dysuria. Over the past 3 years, her prediabetes has progressed to type 2 diabetes, her lipid levels have not reached goal, and her blood pressure has worsened to new onset hypertension. Today, her fasting plasma glucose is 157 mg per deciliter, but her foot exam is unremarkable and she has no signs or symptoms of peripheral neuropathy. She is willing to make changes to control her diabetes, but she is still on the fence about using injectable medication. Her HDL and LDL have improved with high-intensity atorvastatin. Her fasting HDL is 56, her LDL is 105, her triglyceride is 210, and her total cholesterol is 227. Her HSCRP, which is a non-traditional risk factor for dyslipidemia, has improved from 3.4 mg per deciliter to 2.2, but it should be less than 0.8 mg per deciliter. Today, her blood pressure readings are 147 over 89 and 148 over 92. Her heart rate is 72, and her blood pressure levels measured at home are similar. And secondary causes of hypertension have been ruled out. She has lost 10 pounds over 3 years. Her current weight is 168 pounds, her BMI is 28.7, and her waist circumference is 36 inches. She has reduced her salt and cholesterol intake, and she's working hard to improve her diet to reduce her cardiovascular risk. She likes to splurge on occasion, however, and she has not started a low carbohydrate diet. She states she wants to continue to lose weight and she walks 3 times per week. However, this has been recently limited due to the osteoarthritis pain in her knees. She reports compliance with her medications, that she never misses a single dose. Her past medical history includes obesity, she's postmenopausal, metabolic syndrome, dyslipidemia, elevated blood pressure, prediabetes, and osteoarthritis. She has a 25-pack year smoking history. She quit in 2003, and she does not drink. Her mother died of a heart attack at age 62, and her father has type 2 diabetes. Her current medications are atorvastatin 80 milligram orally daily, aspirin 81 milligram daily, metformin 1,000 milligrams twice a day, and acetaminophen 650 milligrams as needed for pain. She experiences anaphylaxis with penicillin. Her prioritized problem list is dyslipidemia, diabetes, hypertension, and obesity, all at high priority, and metabolic syndrome, renal insufficiency, and osteoarthritis of medium priority. Assessment of her type 2 diabetes is uncontrolled. Her fasting plasma glucose is 157, and her A1C has been trending upwards over the past 3 years from 6.3% to 7.2 to 7.6% today. Her recent UTIs and yeast infection may be complications of uncontrolled blood glucose, and diabetes is a known risk factor for increased risk for UTI. She has an elevated bicarbonate of 28 millimoles per liter and an elevated anion gap of 9 milliequivalents per liter, and these are key parameters for developing and diagnosing diabetic ketoacidosis. And the rationale here is that although she does not have or meet all the criteria for diabetic ketoacidosis, it's just another indication that the uncontrolled blood sugars are causing other symptoms. The contributing factors are obesity, African American race, dyslipidemia, family history of type 2 diabetes, signs of insulin resistance such as hypertension and dyslipidemia, long-standing history of inactivity, metabolic syndrome, and she has not started the low carbohydrate diet. Her current therapy with metformin 1,000 milligrams twice daily is suboptimal. Her goals of therapy are to achieve an A1C less than 7%, which is appropriate. However, we also may have her use a more stringent goal of less than 6.5% if significant hypoglycemia and risk for adverse effects from polypharmacy can be avoided. We want to delay the progression of her diabetes complications and decrease her ASCVD risk, and to have patient collaboration on treatment goals and plans. For the diabetes plan, I recommended to start a DPP4 inhibitor, sitagliptin, 100 milligrams orally daily with or without food. The rationale here is that her current 10-year ASCVD risk is 20.6%, her optimal risk is 3%, and based on ADA 2018 guidelines, recommend that intensified lifestyle therapy and add-on therapy to metformin with an agent proven to reduce major adverse cardiovascular events or cardiovascular mortality is recommended. As well, in the TICOS cardiovascular outcomes trial published in 2015, showed there was no difference between sitagliptin plus usual care compared with placebo plus usual care for type 2 diabetics for risk of first cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalization for unstable angina, which was the composite primary outcome, or heart failure. Each new class of add-on therapy generally decreases A1C from 0.7 or by 0.7 to 1%, and DPP4 inhibitors have a neutral effect on weight. Sitagliptin also meets the patient preference for oral therapy. For safety, advise the patient to report any hypoglycemia, defined as less than or equal to 70 mg per deciliter, or if she has signs of shakiness, irritability, confusion, tachycardia, or hunger, or hyperglycemia, and monitor for diabetes-related complications such as renal function, retinopathy, neuropathy, and foot health. And that sitagliptin may cause headache, nasopharyngitis, or upper respiratory tract infection. Also, concurrent use of aspirin and metformin may increase risk for hypoglycemia. For efficacy with sitagliptin, we will monitor A1C every 3 months with a change in therapy or when her glycemic goals are not being achieved. And point of care testing may guide more timely changes in therapy. And as well, we can decrease her frequency of testing to once or twice yearly when her A1C becomes stable. For follow-up, refer the patient to the ophthalmologist for a dilated eye examination due to the risk of diabetic retinopathy and microvascular complications, and the osteoporosis screening to assess for wrist fractures, which may occur from hypoglycemia-associated falls. For patient education, advise the patient that her UTIs and yeast infections may be related to her uncontrolled blood sugar. Recommend that the patient start the self-monitoring blood glucose and diabetes self-management education and support programs to improve her life and maintenance of glycemic goals, including her foot care, and to consider frequency of testing in the morning and before or after meals. And the rationale here is that more frequent SMBG in type 2 diabetics is associated with meeting A1C goals. And also we want to regularly review or teach SMBG techniques and how to evaluate the results to guide her diet or eating habits. Also advise the patient to report any signs or symptoms of hypoglycemia, any swelling, numbness, or tingling in the limbs, any falls, unexplained headache, nasal or throat inflammation, or chest infection. We also want to encourage the patient to continue her diet and exercise therapy and to start her low carbohydrate diet and initiate a more intense, structured intervention to meet her dietary and caloric goals. I also suggest using a physical trainer to meet her activity goals, such as the 150 minutes of exercise per week of intensity similar to brisk walking, and she can achieve this through swimming or aqua aerobics or cycling to help avoid the aggravation of the osteoarthritis in her knees. Assessment of hypertension is new onset hypertension. Her baseline blood pressure were 126/76, 129/73. Her current blood pressure is 147/89 and 148/92, and she has similar blood pressure measurements at home. Her ASCVD risk, 10-year risk currently is 20.6, and her optimal risk is 3%. The combination of her current blood pressure level and the similar blood pressure levels from home being greater than 140/90 meet the criteria to promptly initiate pharmacotherapy. As well, blood pressure greater than or equal to 140/90 classifies her hypertension as stage 2 hypertension, and initiation of pharmacotherapy with 2 agents from different pharmacokinetic classes in combination with non-pharmacotherapy is recommended. She is currently not on any therapy for the hypertension. Her contributing factors are dyslipidemia, high-fat diet, obesity, abdominal obesity, long-standing history of inactivity, metabolic syndrome, and her family history of ASCVD. Her goals for hypertension are to achieve a blood pressure goal less than 140/90 or a more stringent goal of 130/80. which is recommended with high risk for cardiovascular disease if it can be achieved safely. Another goal is to reduce her ASCVD risk to 3% and her risk or progression or microvascular complications, heart failure, and kidney disease. For her hypertension plan, we want to discontinue the planned therapy with lisinopril. And the rationale here is that the patient does not have albuminuria. The risk of progression of kidney disease is low. Her ACEs and ARBs, or the ACEs and ARBs class, have no priority for cardiovascular benefit compared with thiazide diuretics or dihydropyridine calcium channel blockers in the absence of albuminuria. As well, a subgroup of African American patients in the ALHET trial published in 2005 has significantly greater decrease in systolic blood pressure with chlorthalidone versus lisinopril. And chlorthalidone provides significantly better cardiovascular benefit. In addition to intensifying her lifestyle modification and for secondary prevention of ASCVD, we will start dual antihypertensive therapy with agents of different classes, chlorthalidone 12.5 milligram orally daily. The rationale is that chlorthalidone is a preferred primary oral hypertensive agent due to its prolonged half-life and trial-proven decrease in cardiovascular disease, and also that the ALHAT trial showed chlorthalidone compared with lisinopril provided significant cardiovascular benefit for combined CHD, combined CVD, stroke, and heart failure in African American subjects. The second agent is amlodipine 5 milligram orally daily. The rationale is for the use of a second agent for stage 2 hypertension, which is an agent of a different class, and that the classification of stage 2 hypertension includes patients with diabetes or CKD. For safety, we'll monitor her electrolytes and renal function 2 to 4 weeks after starting therapy. Look for any dose-related pedal edema with amlodipine, which is also more common in women. Monitor for hyponatremia, hypokalemia, uric acid and calcium levels, orthostatic hypotension, weight and hypovolemia, heart rate, blood pressure, and medication tolerance. As well, concurrent use of aspirin and chlorthalidone may decrease the diuretic efficacy and possibly cause nephrotoxicity. For efficacy, we'll look for achievement of our blood pressure goal, either less than 140/90 or less than 130/80, if it can be achieved safely. Also for reduction in her ASCVD risk. And her efficacy may be achieved by titrating doses of either chlorthalidone or amlodipine every 2 to 3 weeks if needed, or faster or slower based on clinical judgment. And this statement is supported by the ASH Hypertensive Guidelines of 2014. For patient education, she needs to continue her home blood pressure monitoring and keep a diary of her readings and bring them to her follow-up appointments. We want her to continue to intensify her lifestyle modification with weight loss, low sodium, and increased potassium intake, moderation of alcohol use, and increased physical activity. Start her low carbohydrate diet, and advise the patient that hypertension is a lifelong commitment and that she should continue to take her medication regularly and to not stop her medication without physician guidance. We also want her to report any symptoms of fluid retention in her extremities, lightheadedness, faintness, or low blood pressure upon standing. For assessment of her dyslipidemia, it is uncontrolled. Her fasting lipid panel has improved since her previous measurement, but her LDL and her triglycerides and her total cholesterol have not met goal. Her current cholesterol is 227 mg per deciliter. Triglycerides are 210 mg per deciliter, and her LDL is 105. Her ASCVD risk, her 10-year risk is currently 20.6%, and her optimal risk is 3%. She is still at high risk for ASCVD, which is defined as 2 or more risk factors and a 10-year risk between 10 and 20%. Her triglyceride levels are classified as high between 200 and 499 mg per deciliter, which increases her risk for acute pancreatitis. However, the triglyceride measurement alone is indeterminate. Her elevated HSCRP of 2.2 mg per deciliter should be less than 0.8 mg per deciliter, and this is a non-traditional risk factor for ASCVD. Her contributing factors are high saturated fat diet, occasionally splurging on her diet, obesity, abdominal obesity, family history of CVD, history of inactivity, and previous smoking. Her lipid goals are an LDL of less than 100, a non-HDL-C of less than 130, triglycerides less than 150, and ApoB less than 90, and also to reduce her ASCVD risk with intensified lifestyle therapy. Her plan for the dyslipidemia is to continue the high-intensity atorvastatin 80 milligram orally daily. The rationale here is that high-intensity statin is recommended for patients with diabetes and ASCVD. And also the cholesterol treatment trialist collaboration of 26 studies showed a decrease in non-fatal cardiovascular events in patients with or without diabetes. For safety, we'll monitor her CPK at baseline and when the patient has symptoms of myopathy, a fasting lipid panel every 3 to 12 months or is clinically warranted. And if 2 consecutive LDL levels are less than 40 mg per deciliter, we need to consider decreasing the dose. And monitor LFTs at baseline and when clinically warranted. For efficacy, we will look for a trend towards or meeting her lipid panel goals and a reduction in her ASCVD risk score. Also recommended for her to start fenofibric acid, 135 milligram orally daily with or without food. The rationale here is that although that the ADA does not generally recommend a fibrate because additional cardiovascular benefit than a statin alone has not been shown. However, fibric acid derivatives primarily decrease triglycerides by 20 to 35%, increase HDL-C by 6 to 18%, and decrease LDL by 20 to 25%. As well, addition of fenofibric acid is patient-specific dual therapy because she has not met her triglyceride, TC, or LDL goals, and she is using the maximum dose of atorvastatin. Also, there were no reports of rhabdomyolysis or drug-associated myopathy in a randomized controlled trial of fenofibric acid added to low, moderate, or high-intensity rosuvastatin, and significantly greater median reductions in hsCRP were observed. For safety, we want to periodically monitor blood cell counts during the first year of therapy and obtain lipid panel 6 to 8 weeks after initiation or if another agent is added to therapy. We can reduce monitoring frequency to 4 to 6 months once her lipid goals are met. If minimal changes to the lipid panel are apparent 2 to 3 months after starting, then we need to discontinue the fenofibrate. Obtain LFTs regularly and discontinue use if they remain greater than 3 times the upper limit normal. Evaluate renal function at baseline at 3 months and every 6 months thereafter. And concurrent use of atorvastatin and fenofibric acid may increase the risk of myopathy or rhabdomyolysis. For efficacy, we'll look at reduction or attainment of her lipid goals and reduction in her ASCVD risk. For patient education, she needs to limit the splurging on her diet to once per month or less so she can meet her lipid panel goals and to continue her heart-healthy diet. Also to continue to take her atorvastatin daily with or without food. Do not break the tablets and avoid drinking large amounts of grapefruit juice, defined as greater than 1 quart per day. Report any unexplained muscle pain, UTI, or confusion or difficulty with memory, and that atorvastatin may cause diarrhea, nausea, insomnia, runny nose, or throat inflammation. And that is it. Thank you.